All right, good morning, everybody. Go ahead and get started here. Is my PowerPoint still showing despite the green line being out on my screen? All right, Terry says yes, perfect. Awesome. Well, thank you everybody for your time this morning. I have been really endeavoring to keep these at 30 minutes or less, and I'm gonna say today's presentation is probably gonna push that a little bit because we got a fair amount of content. So I'll go and get us started. We will skip these Zoom introductions with so many people on, but thank you all. We got an awesome group of people looking on the roster here, so thank you for being here. Going to go ahead and jump to our kudos. So first of all, I wanted to give a shout out and a kudos to the Star Switch team and Central County. They worked through the last couple days improving some of the dispatcher call algorithms. So I know that always takes work to jump into the protocols, but they kind of identified an opportunity for improvement so that trach patients didn't really get identified as alphas, depending on some of the way the family answered some things. And instead, it still triggered a higher level response so we could get more resources to that scene. So I appreciate them tracking that down and making an improvement to the world there. As I mentioned, I am going to pause recording for this part just because we do share these meetings on YouTube, and I would just hate for a family to ever stumble across this. So awesome. And almost, I didn't mean to juxtapose these two so quickly, but I did want to cover a room for improvement too. We saw recently here. I know that I am preaching to the choir in this room, but I'm trying to give the choir more ammunition as we kind of attempt to keep improving EMS and assaulting some of the cultural hurdles within EMS that we see sometimes. So we had a patient who called 911. They were 3.3 miles from the local outside hospital. Family actually, well, we'll get to the specific case. So I just took the specifics from this case and said, okay, what patients would be appropriate for you pick them up and the hospital's only 3.3 miles away and it's a kid, when would it be appropriate to go there? I will say the outside facility did have a PIM who was staffing, so they did have, pediatric services in the ED. So, I think a family request, if the kids had a runny nose for 7 days and the family says we want to go the closest and they have a pediatrician there who can treat it, okay, sure. Other things when they, that everybody wants to go to the example of, what if that kid's just so critical that you can't manage them? And there are a handful of those kids. But I'll point out we're getting better and better in the field. We have our skills, we have our IGILs, we have our tools, we have the ability to oxygenate and ventilate. And if you can maintain that kid, even if they're critical, and get them to a destination facility, a lot of times you'll get them to definitive care much faster. So I kind of left it a little extreme on the end there, but like short of your ambulance being on fire, you probably can make it past and get somewhere else. I get that weather does play a role in this sometimes. I will say this call happened before the recent snowstorm, so that was not a factor in this call. Versus, what are the patients where we're okay in the rest of our practice in EMS with bypassing a closer facility to go to another facility? Obviously, the time critical diagnosis calls. And then, if the family is really insistent or requests to go somewhere, we'll take them there. And sometimes if there's really specialty care services that the patient is receiving, their specialist is there, they don't have any record or anybody taking care of them at that outside facility, why not take them to their destination facility? And I did pick oncology as my example for a reason. So in this call, this patient was not a star at the time, but woke up experiencing shortness of breath, some altered mental status changes. And the family said, we're followed at a children's hospital, unfortunately, the patient has cancer, we're being treated there, we'd really like to go there. And unfortunately, they were given the answer of, we have to stay close to our area, we're not going to take you there. I will point, this isn't the difference between, being one of our more outlying EMS services where it's a difference of 15 minutes versus 4 hours. You kind of saw the times there on the previous slide. The Google mapping gives it 7 minutes versus 21 minutes. So 14 minutes difference there. Upon arrival at that outside facility, they were assessed and immediately the transport team was called to take that kid to a children's facility. They did end up receiving some care. This kid was pretty sick. You know, they're hypokalemic. They had a metabolic alkalosis. So they were sick, but a lot of that treatment actually wasn't rendered until transport arrived at that facility. And so, unfortunately, what kind of from my perspective, we see a lot of lost time. You know, if EMS could have just said, you know, okay, you know, we get that it's morning rush hour, but we're just going to push, you know, for 14 extra miles here and go take this kid to the right facility. Instead, we, you know, have a lot of extra travel, an outside stay at the outside facility of 3 hours. And then that patient and their family unfortunately just picked up an additional bill that they're going to have to pay in the mail. So, you know, I get that there are sometimes extenuating circumstances, but this one I kind of look at and say, you know, I don't know what rules have to be bent, but to me, this is a situation where we do this for other patients, and it really would have been appropriate for this patient to directly transport them to their destination care. So. Just always room for improvement as we kind of talk to our providers and say, you know, okay, why, you know, did you feel uncomfortable? What was it that made you think, you know, the outside facility was preferable? And, you know, if maybe there's rooms or rules we can address to say, you know, that's not really, we can do better by this patient. The one other thing that I always like to kind of tackle in this is, you know, sometimes I hear like, we were the last ambulance in service. We had to get back to cover our district. And I get if you're 4 hours away from St. Louis, how that's maybe an argument. But to me, when you're talking about a difference of 20 or 30 minutes, like you're kind of sacrificing care for the patient that you have in front of you for the potential patient that you don't have yet down the road. And I really think you should try to do a little bit better by the patient right there in front of you. So. All right, enough preaching to the choir. I will get off my soapbox. I'm trying to find a new soapbox. I will try to get one, guys, I promise. All right, we're going to run through the stars numbers here real quick. So for January, you can see a slight uptick in logins and usage of the system. Continue to gain a few more kids each and every month. So currently 795 active. Emergency activations were actually the same as last year, and one fewer dispatch for the month. And then the dispatches there, you can see that went to those agencies. The Jeffco 911 was actually also a JPAD call. So for the 911 provider, that's who received that dispatch. Whoops, I didn't do my count, my bad. Approximately 16 calls for the month of January there. And you can see we just continue to kind of track stats on that. As always, when you take my RFI, like I 100% from my rural agencies get that sometimes you got to go to closer facilities. And then we just track, you know, where was the kid transferred later again, where they admitted, just kind of outcomes on that. So for some of you further out, please don't feel like I'm necessarily yelling at you about that. Just look at each situation on its own. And then SCAD-RAN are only non-transport of the month. And so once again, as always, thankful for that. That was a pretty complicated kid. And so like I said, in the old days, sometimes that's just an automatic transport just because we're not sure what went on here. And I think hopefully everybody feels more comfortable by having that emergency information form available to know that the refusal might be okay in that situation. Those are just the MD approvals, just kind of as we put more kids through. We are kind of resuming some training. In fact, that's where Trisha's gone to today, is out training. And so still being a little bit slow and picky with our dates here in February and March, as maybe hopefully Omicron wave continues to descend. But I think we're kind of looking at later in late spring, like we're just scheduling now. And so we'd love to come out and get some education going again for some of your agencies. I'm going to talk for just a few minutes, and I think intro is the operative word here. I'm clearly not an expert in this, but kind of it strikes me as we write STARS plans and have encountered some of these calls coming in, that there is still kind of room to improve, just, you know, as a field, our understanding of what these calls mean and potential outcomes to some of the pediatric hospice calls. We do continue to kind of see our units called out to STARS patients or even non-STARS patients who are on hospice. And those situations are often unique unto themselves. They can be kind of tricky. And so kind of wanted to vet out ways maybe we can improve our knowledge base on this. Questions that I've seen over the years, or things I've, heard crew members tell families, like, yeah, you're choosing to come off hospice. And sometimes that's said with a different tone, depending on what scene you're on, if you're going to go to the ED. And so, what does it actually mean though? And what can we do? So I didn't see if my palliative person was able to join. But I did invite Miss Amy Roddy, and that's who I got some of these answers from. So, we kind of started with, how does a patient even end up on hospice? And, that's generally kind of led from teams here at the hospitals, through conversations with the care teams and the family. And kind of when we determine that point of, we're now going to focus on quality of life versus extending life medically. And, what does that look like? Does this patient or family need some more resources to help with that? And so then just for my MSers, like that leads to an order set, much like a DME and equipment ordering. They say, okay, this are resources that this family needs, and they order it through a hospice company. And then that hospice company will set up a plan for that family and a program, and it's sort of between them and the family. One thing I was kind of surprised to learn is that, the hospital kind of learns the wishes from the family and passes those on, but it's not really the hospital that writes the hospice care plan. It's the hospice company, obviously with influence from the doctors and prescriptions as needed. But to one of my question now, that was like, okay, well, is there a plan we can ask for on scene? And that's not always clear. That kind of varies with the company a little bit, and what their plan and program is. Because I think in a perfect world, what we'd see is that hospice plan matches whatever the hospital has on record, and we can write into the STARS plan and kind of tie all those neatly together. So possibly some room for improvement for us there. So why do we get called? I mean, in our experience and talking to our coworkers, kind of two main tracks, right? Sometimes the family panics. End of life looks very differently to lay people, and depending on their life experiences and knowing what to expect in that situation. And is gasping breathing just them short of breath this morning, or is gasping breathing unfortunately the end as the system starts to shut down? And for any family dealing with a hospice patient, that can probably be a real gut check. It's one thing when it's theoretical and in conversations in the hospital, but to watch your loved one actually dying there in front of you, that does lead to a change of mind, or even uncertainty, right? Like, well, maybe this doesn't have to be the exact end. Maybe we can render a little care and still last longer. And so I think those questions probably start to get into families' minds and lead to that uncertainty, which triggers a 911 call. Sometimes also, the plan just goes awry. They're on hospice for this, but they get an infection from somewhere else, and then you're in that same uncertainty. Like, do we need to be treating them or not? Is this related to their disease or not? Also, one thing I didn't really consider until our conversations with my palliative team, but the hospice plan for some patients actually looks like they want to come back to the hospital to pass. The ultimate goal is hopefully as they reach that point, family will bring them back in. But especially in some of our older peds patients, what we see is, they're bigger, they're heavier, some of them are adult size. And if they're too obtunded or the family can't move them anymore, we have to find a way to transport them back to the hospital. And so sometimes, the best laid plans go a little bit awry, and you may end up seeing a 911 call just for a patient, essentially a home to hospital transfer, so that they can follow their plan and get the care that they need. I think another challenge that you'll see, as we kind of discussed with my palliative team, is, in pediatric hospice, there's already kind of a lack of resources, and the more rural you get, the more challenging that is. And so, unfortunately, I think what families also sometimes hear is, they have a hospice number to call, a nurse, some coordinator, but they might receive the answer like, oh, well, that person's 3 counties away. They'll get to you as quickly as they can. And that can, that's another challenge on that family, as they try to consider like, well, what if we could get some care right now, or get some help here right now? And so I think that paucity of resources definitely lends to the challenge of the situation. I'll try to kind of wrap up here, as I know I'm pushing 30 minutes, but these were just some of the questions I asked and the answers I got. That family is welcome to call 911 anytime they want to go to the ED. Or even, just needing resources, somebody, a healthcare provider to come evaluate something on scene, whether they're not sure their pulse ox is working correctly or some medical equipment. If the patient is transported, it does invalidate the hospice. So at least if the patient's admitted, especially from that. But as they pointed out, all it is they just resubmit the orders if the family wants to go back onto hospice after that event. So while it is a truth that it invalidates it, it is not necessarily a huge limiting block in that patient's course. They just will need to reapply for hospice. So as far as EMS contacting, hospice from scene, especially in a subacute situation, I think that's actually highly warranted to communicate with them about the patient's hospice plan and what the family wants to have happen. A little bit trickier in the more acute cases where you're maybe having to make decisions a little bit faster. But I would, if at all possible, if somebody can be helping the patient, try to reach out and talk to whatever phone number that family has for the hospice company. And then they can also help arrange, if the patient passes while you're in your care. We mentioned in last month's meeting, we recently had an example of this where the patient did pass during EMS transport, and they did transport to the local facility, and that was where the patient was declared dead. So there is kind of a difference between different companies. We're very lucky to have here in the St. Louis area within the 50-mile radius. We have Wings. But as I said, there's not always pediatric resources beyond that. A lot of times it's a home hospice or an adult hospice company who is convinced to kind of take on a pediatric patient. So there's not always a lot of resources further away, and sometimes their response times are a little bit slower. And then just, when is it appropriate to take that patient to the ED? If the family says so, just like the DNR or the Pulse, they can change their minds at any time. So, what do we do? I kind of just wanted to leave it at this, and we can, like I said, we can call this an intro, and I think there's a lot more that can be explored in all this. But, kind of how do we help our medics and our EMSers navigate these? And I think understanding, the truth, there's a lot of folklore that goes on in these kinds of calls in these situations that's been passed down through the trucks through the years. And kind of a more accurate understanding of exactly what hospice is and how it works and how 911 interacts with it. And just some, important questions to have when you walk in on that scene. Did you call us here because you want us to support the hospice plan and the hospice measures, or have you changed your mind and you want us to transport to the ED? I think that's kind of an important distinction to make with the family. Asking what the plan and the end of life plans look like. If you can get the contact info for the hospice staff, I think that's really important to see, if they're going to come and arrive and be able to provide resources, or if there's something you can do in the meantime to help support. And then really just determining, do you guys want to go to the ED? I think that it doesn't need to be a judgmental or a critical question. It's not really on us. Once again, we're not officially licensed counselors, and we're not officially licensed palliative staff to say, oh, these are the rules and the regs. Like, no, we just like, hey, we kind of understand this. We think this is what it is, but what can we do here to help you guys have a good outcome? And if ED transport is it turns out we're very good at that. So, please, by all means. Hopefully we still got some empathy left out here in the field. I think we got a lot of people who do, and certainly, for pediatric hospice patients, I hope if you got none left anywhere else in your tank, you got some for them, because those are challenging situations. So, all right. I know I went just a little bit over. I apologize. That was kind of a little bit of heavier material than our average meeting here today. Were there any open forum questions or comments? Anything anybody wanted to go over? All right. One real quick thing I want to address. It seems like a little bit more recently, within the last month and a half, I've encountered a lot more agencies. I guess there's some more email security on in the world, and IT is flipping more and more switches. So we have encountered a few more instances where our emails from the STARS website are not making it through to your providers when you register them or change their passwords. So just a reminder that there are some emails that have to be whitelisted. Absolutely, I can paste those in chat off my other screen, Ms. Stephanie. I will put that there in just a second. So those just have to be whitelisted so that you can receive those notifications out of the website. So, and then for anybody who wanted to hang on, Doc Laffey was going to show us some footage from that resuscitation. So I'll go ahead and stop the recording there.